So in part C of Chapter 4, we're going to talk about heart failure. And in particular, we're going to talk about systolic heart failure because I think that the physiology is a little bit more interesting. And at least at this point in time, there's a little bit more to talk about in terms of how changes in intrathoracic pressure affect the physiology of left ventricular systolic dysfunction. So there's good clinical data to suggest that in states of pulmonary congestion, there's a reduction in pulmonary compliance. So we're going to talk about the Campbell analysis first, just like we did with obstructive airways disease. So as the lungs increase their water content, it's classically modeled after occurring in stages, which tend to correlate with the severity of the alteration in pulmonary mechanics. Pulmonary congestion, and I talked a little bit more in depth about this in Chapter 5, Physiology of Extubation Failure, but pulmonary congestion is the term used for increased lung water without any extrusion of fluid into the interstitium. This stage is then followed by bronchovascular interstitial edema and then alveolar interstitial edema. And then lastly, frank alveolar edema occurs, and this tends to be an all or none event, that when they look at alveoli under the microscope, they tend to be either full of water or not. It's so-called quantal filling or quantal phenomenon. Systolic heart failure is therefore an example of how the cardiovascular system can mechanically alter the respiratory system. Any process that results in left ventricular dysfunction, to the extent that the wedge pressure is elevated, congestion can lead to aberrations in both compliance and airways resistance. So we frequently see pleural effusions in the intensive care unit, and certainly in patients with bad heart failure. And the way you should think about a pleural effusion, I'm not going to go into a huge amount of detail on it in these slides, but I want you to think about pleural effusion as a space-occupying lesion within the thorax. And therefore, I want you to sort of think of it like a space-occupying lesion within the brain or within the skull. And therefore, its effects are largely dependent upon chest wall compliance, and you sort of think of the chest wall as like the cranium. In the skull, which is a fixed vault, small changes in volume can result in very large changes in intracranial pressure, and that's bad, as any of us who've worked in a neurointensive care unit know. And you can apply a similar analogy to the thorax. If the chest wall compliance is very poor, that is non-distensible and rigid like a skull, then the space-occupying pleural effusion will lead to more collapse of the lung and elevate intrathoracic pressure to a much greater extent. If thoracic compliance is kind of normal, or even if it's increased, the space-occupying pleural effusion tends to be much less of a hemodynamic insult. And there's a number of review papers talking about whether or not bilateral pleural effusions in patients in the intensive care unit should be drained because it may improve cardiovascular status, but really that should only be undertaken when the patient's thoracic compliance is very poor, because really that's what causes the greatest hemodynamic consequence. So let's talk a little bit about systolic heart failure. In a way, we talked about obstructive airways disease. So there can be volume and pressure effects, sort of like we talked about with in emphysema in the previous section. So the volume effects are not so much like a dynamic hyperinflation that you see in obstructive airways disease, but this tends to be more of a result of increased lung water content. And so this can impair venous return. It tends to increase pulmonary venous return because the pulmonary vessels are engorged with blood, so as you increase lung volume, there's more blood squeezed out into the pulmonary veins and into the left heart. It tends to, by similar physiology, increase the mean systemic pressure because of the engorged venous vein, or the engorged veins in the systemic vessels. And there tends to be a decreased resistance to systemic venous return, and that's because there tends to be less of a vascular waterfall effect established as the great veins enter the thorax. The volume effects increase lung water on the heart, increases right ventricular afterload, and multiple effects here, including hypoxic vasoconstriction, but also a little known physiology that's commonly called West Zone 4 physiology, and that's when interstitial pulmonary edema can collapse the extraalveolar vessels, and that collapse of the extraalveolar vessels can increase pulmonary vascular resistance. Certainly valvular incompetence, both tricuspid and mitral, can occur, and certainly the systolic dysfunction in and of itself. The pressure effects of heart failure is fairly similar to what was seen in obstructive airways disease, that there's low intrathoracic pressures during inspiration, and that can be mitigated by pleural effusions to a certain extent, and higher intrathoracic pressures during a forced expiration if the patient's breathing spontaneously. And that can affect, again, the venous return curve and the cardiac function curve. So on the venous return curve, this tends to increase maximal venous return. So in patients who have a high right atrial pressure to begin with, because of a shift rightwards of their systemic venous return curve, then when they lower their intrathoracic pressure, there can be a much greater effect on venous return as you drop the downstream pressure. Certainly there's variation in inspiratory and expiratory filling that flows from what I just said, and by similar physiology and increased pulmonary venous return curve. And then in terms of cardiac function, there can be an LV diastolic incompetence via ventricular interdependence if the right heart is engorged with blood, as can be seen in biventricular dysfunction that can be a consequence of left ventricular dysfunction. And the effects of intrathoracic pressure have a much more pronounced effect on left ventricular afterload, as I'll talk about in a few slides. So now let's go over the Campbell analysis in terms of heart failure. So again, pulmonary elastance curve, chest wall elastance curve when there's no activity of the muscles of inspiration or expiration. The intersection of the two defines functional residual capacity. Again, this is the normal state. So the functional residual capacity defines a certain lung volume for a certain intrathoracic pressure on the x-axis. This marks 0 or atmospheric pressure, so this is pressure above atmosphere, pressure below atmosphere. So functional residual capacity, again, when you take a normal inspiration and expiration, what's happening is your chest wall elastance curve is actually shifting as the muscles of inspiration are activated during inspiration, and then passively the lung recoils on itself as pressure is stored as elastic recoil pressure at the end of inspiration. But imagine a lung that is completely engorged with water and alveolar edema and bronchovascular interstitial edema. Well, that lung compliance is decreased, or its elastance is increased. So this is shifted down and to the left. And you can see if you assume that chest wall compliance stays the same, which it frequently doesn't, but assuming that it does, your functional residual capacity will decrease and your intrathoracic pressure will be decreased to a certain extent. So there tends to be an increase in airways resistance as well with pulmonary edema, and this is probably due to bronchovascular interstitial edema collapsing the airways in a similar way to which it collapses the pulmonary arterioles and raises pulmonary vascular resistance. So the dynamic component to the Campbell diagram tends to be shifted leftwards here, so there has to be a lower intrathoracic pressure generated to drive gas flow in these patients. And again, I've indicated here there's been no change in chest wall compliance, but in clinical practice, chest wall edema and ascites are commonly seen in these patients, and that will significantly alter chest wall compliance. And I talk a little bit more of that physiology in the last section of this chapter when we're talking about cirrhotic patients. And then forced expiratory efforts will increase intrathoracic pressure on expiration. So if this patient is grunting and bearing down, and there's sort of rapid shallow breathing here to minimize the increased elastic work of breathing that they get with poor lung compliance from the pulmonary edema, then in order to maintain a high minute ventilation and to overcome the increased airways resistance that you can get with pulmonary edema, they often grunt and force that expiratory breath out, so there can be a very high expiratory intrathoracic pressure when they get back to and you get back to functional residual capacity. So let's talk about the spontaneously breathing patient and the effects on the right ventricle. And again, this is the Campbell analysis down on the z-axis into the page. This represents the unaltered chest wall compliance curve here. And this represents the diminished pulmonary compliance curve here. This is the increased airways resistance, the increased expiratory airways resistance, and this is functional residual capacity. Pleural pressure is on the x-axis. Again, this is 0 or atmospheric pressure. All the pressures here are above atmospheric pressure. This is below atmospheric pressure, and then the z-axis going into the page is lung volume or thoracic volume. So let's go through an inspiratory-expiratory cycle just to review. So again, I talk about this in Chapter 1. These patients with a diminished pulmonary compliance or diminished chest wall compliance have a very large increase in their elastic work of breathing. And so to minimize that effect, they tend to breathe at small volumes. But in order to maintain minute ventilation, they have to therefore increase their respiratory rate. So they engage in what is commonly seen as rapid shallow breathing. And this has a lot of effects that I talk about in Chapter 1, including increasing your fractional or your physiologic dead space, so you can get carbon dioxide retention just from rapid shallow breathing. If you sort of imagine panting, it's similar physiology. So this patient begins at FRC, inspires, low intrathoracic pressure, expires, high intrathoracic pressure. And now let's superimpose the Guyton analysis. So now we've changed the x-axis. This is now right atrial pressure in millimeters of mercury. This is your CVP, or right atrial pressure, measured here. It's referenced to atmospheric pressure, so this is what you know from your central venous pressure catheter. This is your right ventricular cardiac function curve, and this is your systemic venous return curve, and this is vascular waterfall physiology, where you get collapse of the great veins that are entering the thorax, so this is maximal venous return. Again, this is your intrathoracic pressure. So in this patient who we'll say has bad systolic heart failure, and they're coming in after a week or two of not taking their Lasix and eating big salty meals, and so their total body salt and water overloaded, their venous return curve shifts rightwards. And this can only be determined by a good clinical examination. Unfortunately, there's no readily available clinical diagnostic objective test that can determine that a patient is volume overloaded. You got to talk to the patient, you've got to examine the patient. There's no way around it. So this patient's mean systemic pressure is increased, and that's because as we learned in Chapter 2, the mean systemic pressure is determined by your stressed volume over the compliance of your venous capacitance bed. So this patient's stressed volume is way up because of their salt and water overload. And again, I sort of talk about this, I think, in Chapter 3. If you imagine your venous capacitance beds, which hold 70% of your blood volume at any one time, and if you think of it as like a water bed, if you fill up that water bed, the pressure in that water bed, the pressure felt on the wall of that water bed, which would be like the summative transmural pressure of the venous capacitance bed, will go up, and there will therefore be an increase in the pressure head driving venous return back to the heart, or in the waterbed analogy, it would be forcing water out of the waterbed. So this patient may also have an aspect of right ventricular function as a consequence of dysfunction of the left ventricle. Remember, anywhere from 50 to 80% of the systolic pressure generated by the right ventricle is actually thought to be generated by contraction of the left ventricle. So it's hard to imagine patients with severely depressed left ventricular function without some degree of right ventricular dysfunction as well. So it's shifted down into the right. And what you get is a higher pressure measured by your central venous catheter. And because the venous return curve is shifted rightwards, you actually may maintain cardiac output. If venous return curve wasn't also shifted to the right, you would have a decrease in your cardiac output compared to here. And in actuality, that's probably why when you have heart failure and you have poor forward flow, the body's response is actually to become salt and water avid, right? You release renin-angiotensin aldosterone, ADH, and you expand your blood volume, and that's really probably in defense of cardiac output. We know with time those adaptive mechanisms can become maladaptive, and that's why we treat these patients with carvedilol and ACE inhibition and spironolactone. But that's the kind of teleological explanation for these compensatory effects. So what happens with inspiration? Well, as we've seen, this x-intercept of your cardiac function curve is what tracks intrathoracic pressure, and at functional residual capacity, your intrathoracic pressure is decreased because of the poor pulmonary compliance that's the result of pulmonary congestion. So this patient inspires, the right ventricular cardiac function curve shifts greatly to the left, and there's an augmentation of right ventricular afterload. And the reason that the right ventricular afterload increases is because lung volume increases. So as lung volume increases above functional residual capacity, you increase your pulmonary vascular resistance. But also, as you increase volume of the right heart, that tends to increase the radius of curvature and therefore increases the wall stress on the right ventricle by a modified law of Laplace. And you can see that during inspiration, the systemic venous return curve shifts to the right even more, and that's effect of that's lung volume effect. As you increase lung volume, you tend to compress the abdominal venous beds, and you therefore augment your mean systemic pressure and increase the pressure head for venous return to the heart. And again, in my silly analogy in Chapter 3, I say that's sort of like if your venous capacitance or your venous capacitance beds are like a water bed, increasing lung volume would be like laying on the water bed. You're going to decrease its capacitance and therefore favor a higher pressure head in that water bed to drive water or blood out of it. So you've increased your distending pressure of the right heart to a great degree, and that's a function of both the increase in right ventricular afterload, the decrease in intrathoracic pressure, and also the increase in mean systemic pressure in total body volume, which tends to bolus the right heart during an inspiratory maneuver. So this, as you can imagine, can greatly strain the RV and also LV by ventricular interdependence. Forced expiration has kind of just the opposite effect. Your venous return curve shifts back leftwards as lung volume is decreased, and intrathoracic pressure increases, so you shift the right ventricular cardiac function curve rightwards. Some of the afterload effects on the RV are mitigated as lung volume decreases, and you can see a much lower cardiac output during this forced expiration despite the increase in measured right atrial pressure. So you can see right atrial pressure here on expiration is measured here, and your cardiac output is here. And then on the forced expiration, you've decreased your cardiac output, but you've increased your measured right atrial pressure. And you can see here that the distending pressure of the right ventricle and right atrium and right ventricle at diastole has decreased, because even though the measured intraluminal pressure has increased, because the intrathoracic pressure here has increased, the pressure inside the vessel less the pressure outside the vessel has actually diminished. So on a forced expiration, you might actually diminish right ventricular volume, which would tend to improve left ventricular mechanics or left ventricular diastolic properties via ventricular interdependence. So the same discussion flows for the left ventricle. Again, pleural pressure in centimeters of water on the x-axis. This is at zero or atmospheric pressure. This is subatmospheric pressure denoted by negative values, and this is supraatmospheric pressures denoted by positive values. And this is lung volume into the z-axis going into the page. This is your poor pulmonary compliance as a result of the boggy edematous lung. I've indicated a normal chest wall compliance here. This is your diminished functional residual capacity. Inspiratory airways resistance, expiratory airways resistance, and this patient is rapid shallow breathing. So here we go. Inspiration, low intrathoracic pressure. Expiration, high intrathoracic pressure. Back to functional residual capacity. So let's go over the same thought experiment, but with the superimposition of, again, blood flow on the y-axis. But now we have left atrial pressure in millimeters of mercury on the x-axis. This is pulmonary venous return. This is your left ventricular cardiac function curve. And again, as I've said multiple times already, I have not animated this, but during changes in intrathoracic pressure, be it down or up, the pulmonary venous return and left ventricular cardiac function curve will shift in tandem, left and right, with the decrease and increase in intrathoracic pressure. So that what I'm trying to say is that decreases in intrathoracic pressure per se do not alter the relationship of the left ventricular cardiac function curve to the pulmonary venous return curve, and that's because the pulmonary veins and the left ventricle are exposed to the same intrathoracic pressure. So the distending pressure or the transmural pressure does not change purely as a result of just changes in intrathoracic pressure. They do change relative to each other by other mechanisms that I'll go through right now, but I just want to make it clear that while they're remaining static in this illustration, in life they're actually shifting in tandem. So the venous return curve is shifted to the right with the increased total body salt and water overload, and this is a function of the increase of West Zone 3 physiology in the lung. So the pulmonary venous return tends to shift rightwards, and again, this is LV systolic dysfunction, so the LV cardiac function curve is shifted down and to the right. This was represented essentially a normal patient. So that's what I've written here. And the result, again, is an increase in your wedge pressure or your left atrial pressure, and increase in the distending pressure of the left atrium, which is depicted here. Similar physiology to the right heart. So what does inspiration do? Well, as you inspire, again, this is the ghost of the right heart here. Okay, so watch the right heart. Remember, the right heart greatly increased its distending pressure with inspiration. And what that does is, by diastolic ventricular interdependence, if you watch now the left ventricular cardiac function curve, what it does with inspiration is it tends to shift down and to the right, and that's a consequence of this ventricular interdependence. And also the pulmonary venous return curve shifts to the right as well, and that's because as the lung volume increases, remember on the Campbell analysis into the page, functional residual capacity going up to your new lung volume, to the extent that you increase above functional residual capacity, you also increase the driving pressure for pulmonary venous return to the left heart. And again, it's dependent, this is determined by Brower and colleagues in the mid-1980s, this is dependent upon the fraction of West Zone 3 that you have in your lung. The more West Zone 3 there is with a given increase in lung volume, the greater your pulmonary venous return will be, and that will increase the distending pressure of the left ventricle as well. This is less to do with compressive effects against the free wall of the LV, because lung volumes in patients who are overloaded tend to be diminished and don't have the same profound compressive effects that they can have in patients with lower lobe air trapping that we saw in obstructive airways disease. Forced expiration, then, we saw the ghost of the right ventricular or the right cardiac function curve. Remember, that tends to shrink the volume of the RV, so that tends to improve your diastolic properties of the LV, and also the increase in intrathoracic pressure that you get during a forced expiration tends to afterload the LV, and so you may actually have a somewhat increase in the slope of your left ventricular cardiac function curve as afterload is reduced by the increased intrathoracic pressure. So you see that the left ventricular cardiac function curve and the pulmonary venous return curve are changing relative to each other, and therefore changing the distending pressure of the left atrium and left ventricle and changing left ventricular output, but it is not a direct consequence of the changes in intrathoracic pressure, but it's more effect of the changes in pulmonary venous return and changes in left ventricular preload and afterload. So let's move on to mechanical ventilation of the left ventricle. So again, this is my modified Campbell analysis that I talk about in multiple chapters now. So on the x-axis we have pressure in centimeters of water. This is 0 or atmospheric pressure. This is above atmospheric. This is below atmospheric. So this is the classic Campbell diagram with a normal pulmonary compliance, a normal resting chest wall compliance when the muscles of inspiration are not being activated, and the intersection of the two is your functional residual capacity, which is your your lung volume at the end of a quiet exhalation, and this is your intrathoracic pressure at functional residual capacity. Well, it's a modified Campbell analysis because I've superimposed the compliance curve of the respiratory system. That's the RS, and the respiratory system is the chest wall and lung together. So how do we derive this compliance curve of the respiratory system? Well, again, it is the lateral distance at each volume between the chest wall compliance curve and the pulmonary compliance curve that determines the pressure that the muscles of inspiration must generate to obtain a given volume. And so in the patient who is heavily sedated and maybe paralyzed, you can then say, well, it's also the same amount of pressure that the ventilator must apply at the proximal trachea to obtain that volume. So if we imagine a significant decrease in pulmonary compliance like you get with big boggy lungs full of water from systolic dysfunction, well, now for every given volume that you want to achieve, the pressure that must be generated by the muscles of inspiration if the patient is breathing spontaneously, or that the ventilator must apply to attain this given volume, is much greater than it was in the resting state. So then if you were to graph these in terms of airway pressure, so this is essentially like you have to apply this much pressure to get this volume. So you have to apply this much pressure at the trachea to get this volume, and then here, and then here, and then here. So this is just serial static or inspiratory hold pressures that you get off of a ventilator. Well, you can see that the compliance of the respiratory system is decreased, and it's a function of ultimately a decrease in your pulmonary compliance. And again, I've talked about this as well. There is a very big difference between your plateau pressure here that you measure in the airway off the ventilator, and the pleural pressure, which is the pressure that is generated as the lungs expand against the chest wall. And the pleural pressure in the passive, fully adapted patient with the ventilator, the pleural pressure is determined by the volume over the compliance of the chest wall. So it follows the chest wall compliance curve. And in this patient, where I've denoted a normal chest wall compliance, for this volume, there tends to be not as much of an increase in intrathoracic pressure as you would in somebody with a very poor chest wall compliance, which we'll talk about later. So this would be your plateau pressure measured here at the proximal trachea off the ventilator, and this would be your intrathoracic pressure or pleural pressure, which you are typically not measuring in the intensive care unit, but you can estimate with an esophageal balloon. So when the drop in thoracic compliance in this curve is due to a decrease in lung compliance, then less of this plateau or airway pressure is transmitted to the pleural space, is essentially what I'm trying to say. And then with alveolar edema, as we talked about earlier in this section, there's also an increase in airways resistance. So the peak pressure in these patients can also be increased to a certain extent as a result of the increase in the airways resistance. So peak pressure would be out here somewhere. So mechanical ventilation of systolic heart failure. So again, I've depicted the Campbell analysis that I just showed you on the z-axis into the page. This is the down and out pulmonary compliance curve as a result of the edematous lungs. This is your normal chest wall compliance. This is functional residual capacity, and then this is your airway pressure as a function of the compliance of the respiratory system or the lungs and the chest wall together. So again, on the x-axis, pressure, pleural/airway in centimeters of water. This is atmospheric pressure. This is above atmospheric pressure, below atmospheric pressure. So let's go through a thought experiment. If we apply PEEP to this heavily sedated passive patient, increases in pleural pressure will follow the chest wall compliance curve. So up a given volume, you've increased your intrathoracic pressure from, say, here to, say, here, along up the z-axis into the page and across the x-axis here. And the ventilator breath on top of that will then increase your pleural pressure, say, to there. But on the ventilator, you'll measure an increase in your airway pressure, say up to here, and this is a function of the poor compliance of the respiratory system, which is ultimately driven by your poor pulmonary compliance, and a slight increase in your airways resistance. So that's what happens when you give a ventilator breath. You apply PEEP and then apply a ventilator breath on top of that. So what does this do to the systemic venous return curve and the right ventricular cardiac function curve? Well, this is the patient whose venous return curve is shifted to the right because of salt and water overload, and they've got impaired right ventricular function. So you can see they're essentially operating on the flat portion of the curve, so giving them more volume would not augment their cardiac output. They've got a fairly large distending pressure of their right atrium and therefore right ventricle, and diastole they've got a high measured central venous pressure or right atrial pressure. And then you apply some PEEP. So what's going to happen? Well, you're going to move from your functional residual capacity intrathoracic pressure as demarcated here. You apply PEEP, and the cardiac function curve is going to shift rightward. But interestingly, the cardiac function curve will also shift up and to the left. And why that is for the right heart is kind of a multitude of factors. And it may be that you've recruited atelectatic lung, and you've actually decreased pulmonary vascular resistance because you've diminished atelectatic lung. Maybe you've improved oxygenation and you've decreased pulmonary vascular resistance. Maybe you've increased left heart function by decreasing left ventricular afterload, and via systolic ventricular interdependence, the RV is unable to unload to a greater extent. There's a multiple ways by this can occur. Similarly, the application of PEEP, as we've talked about, has increased your mean systemic pressure, but also because PEEP tends to facilitate collapse of the great veins as they enter the thorax, you've decreased your maximal venous return. So from up here to here, and now you can't increase your right heart flow any greater than this effect. So as a result, you've actually decreased the distending pressure of the right atrium and right ventricle. That's another reason actually why you may shift the curve up and to the left. It's a bit of a chicken and egg argument, but as you decrease right atrial, right ventricular volume, you decrease the radius of curvature, which means that you decrease the tension of the right ventricular myocytes. So now we're going to do a breath on top of this, and you therefore shift the right ventricular cardiac function curve along the intrathoracic pressure, which follows the chest wall compliance curve here, and again this will shift rightwards in step. And what I haven't illustrated it here, I probably should have, is that with that breath you would tend to shift your mean systemic filling pressure even more to the right, and you might, depending on the patient's volume status, in this situation their volume up, you might actually increase venous return to the right heart. So that would tend to defend cardiac output a little bit and actually increase right atrial pressure even more. But I haven't illustrated it here, probably because I was running out of room, probably because some of these slides took a very long time to animate. But to the extent that PEEP and intermittent positive pressure ventilation relieve hypoxemia, reverse atelectus, improve LV function, the right ventricular cardiac function curve will improve as well. So you actually may augment right ventricular output by these effects on afterload. And so, what's the clinical implication of this? Well, certainly it has treatment implications, but also in terms of, volumes, quote unquote, volume responsiveness. This patient was overloaded to begin with. They were on the flat portion of the right ventricular cardiac function curve. Giving this patient volume would certainly not do them any good. But you can see that by these other mechanisms, particularly changing right ventricular afterload, you can actually cause variations in right ventricular output that have nothing to do with the volume status of the patient. So in this patient, you could argue, and it's possible physiologically, that you could get pulse pressure variation in this patient, but that does not necessarily mean that this patient needs volume or even is volume responsive. So as we've seen, elevated intrathoracic pressure tends to lower cardiac output, mostly by impairing venous return to the right heart. And the mechanism is that there's a reduction in the end diastolic volume or preload, and this predominates in the normal situation, in the normal heart, and therefore stroke volume is reduced. In overload states, however, venous return is rather hardy because of the increased mean systemic pressure. As we saw, the venous return curve is shifted way to the right, or far to the right, or the pulmonary venous return curve is shifted far to the right. So to the extent that positive pressure can reduce, now this is very important here, it can reduce end systolic volume more than it reduces end diastolic volume, the stroke volume will actually be increased. And I've got a slide here that I think will animate this fairly. So on the x-axis here, this is a Sagawa pressure-volume relationship, and I talk about this to, I think, more extent in Chapter 2. This is volume on your x-axis, and importantly, this is transmural pressure on the y-axis. So this has implications for intrathoracic pressure, because the transmural pressure will be the pressure within the left ventricular cavity or the intrathoracic aorta, less the pressure around it. So that would be less intrathoracic pressure. So as you decrease intrathoracic pressure, you're actually increasing the transmural pressure. So the effective pressure is increasing on the y-axis as you decrease your intrathoracic pressure. So this is a normal, say, end diastolic pressure volume relationship. You can see as you volume load the left heart, you can increase the volume to a certain extent, and pressure doesn't increase all that much. And then suddenly the transmural pressure starts to go up, and that's because the cavitary pressure starts to go up. And this is your end systolic pressure volume relationship. So this is your normal ejection. This is you fill to your end diastolic volume. You have isovolumic contraction. You then reach your diastolic pressure. And I have ignored, as those of you who've watched Chapter 2 know, or those of you who just know from medical school, that when you start to eject, you actually kind of get a curved pressure-volume relationship. And I've negated that here because the curved nature of that pressure-volume relationship, it really is the result of the interaction between the time-varying elastance of the left ventricle and the time-varying elastance of the aorta, and I'm sort of just taking that effect out to make this a little bit more simple. But you eject, and then your volume decreases, and then you reach your end systolic pressure volume relationship. Your aortic valve closes, and then the pressure within the LV drops, and then now you're at your end systolic volume. End diastolic volume, end systolic volume, so that's the difference between the two is your stroke volume. So when the normal heart ejects, the tension that the myocyte is feeling throughout that ejection, as you know, is a function of the transmural pressure, but it's multiplied by the radius of curvature. And so for the left ventricle, you can understand or appreciate that as it begins to eject above its as the pressure within the left ventricle reaches the diastolic pressure, the aortic valve pops open and the left ventricle begins to eject. Well, during that ejection, the radius of curvature is decreasing, and the radius of curvature decreases to a normal amount in the normal heart, and that reduces the tension during a normal cycle in a normal heart as the radius of curvature decreases. So there's less of a transmural pressure effect in terms of the wall stress that the myocyte feels. It becomes much more pronounced in the patient with systolic dysfunction. So in the patient with systolic dysfunction, the end systolic pressure volume relationship is shifted down and to the right. So these patients tend to fill at a higher end diastolic volume, and therefore they have a higher end diastolic filling pressure. This is assuming there's been no change in diastolic characteristics in this heart. And now when this patient ejects, there's an increase in the transmural wall pressure of the LV, and this is going to depend on certainly on your diastolic blood pressure when the aortic valve opens. And then again, I've negated it here, but this would also depend on the elastance of the aorta during the ejection. But as you can appreciate, that in this patient with a very high end systolic volume, the radius of curvature of this patient, the stroke volume is very small, or small compared to this, so the radius of curvature of this patient is actually not really decreasing all that much during this ejection cycle. So remember, the tension on these myocytes is the radius of curvature multiplied by the transmural wall stress. So throughout this entire ejection, the radius of curvature is still staying quite hardy, and so there's a much greater tension effect on these myocytes, and therefore the effect of the transmural pressure will be magnified in patients who have a dilated LV. So what happens in this patient when you could really say administer, say, nipride, or you could say apply positive pressure, because both of those interventions decrease your preload, but they also decrease your afterload. So why does nipride improve stroke volume in patients with impaired systolic function? Well, it's the same reason that positive pressure improves your stroke volume. They both decrease your end diastolic volume by reducing preload. Nipride is a venodilator, and therefore you have less return to the heart. Positive pressure retards blood flow into the thorax, so you have less venous return. But there's a greater effect on the transmural wall stress in both. And this is illustrated here. This is the decrease in preload, but this is the decrease in the transmural wall stress. Well, from nipride, it's because you're lowering the pressure in the systemic vessels, so the intraluminal pressure is going down. So that would decrease your transmural pressure. That would be this effect here. But positive intrathoracic pressure has the exact same physiologic effects on the left ventricle and intrathoracic aorta as nipride. Nipride's reducing pressure from within the cavity and therefore reducing transmural pressure, but increasing your intrathoracic pressure is similarly decreasing your transmural pressure by decreasing the pressure outside of the left ventricular cavity. So you can see that because the ventricle is hardy to preload reduction, it has a much more pronounced response to afterload reduction. So again, greater cardiac output at a lower filling pressure. So if you were to graph this on the Guyton analysis, greater stroke volume, so the y-axis, the blood flow would be higher, and this would be at a lower filling pressure. So your filling pressure, instead of up here, right, is now your filling pressure is down here. So greater output, lower filling pressure. So this is essentially a shift up and to the left of your cardiac function curve on the Guyton diagram. So let's talk about mechanical ventilation of heart failure in terms of the left ventricle. So again, we'll go through this thought experiment. Functional residual capacity, you apply PEEP, your intrathoracic pressure increases along the chest wall compliance curve in this passive sedated patient. This is pleural pressure or airway pressure when we're dealing with the respiratory system compliance, as discussed previously in centimeters of water. 0, this is positive pressure. This is negative pressure, reference to atmosphere. And then with the ventilator breath, the intrathoracic pressure increases along the chest wall compliance curve, and the airway pressure increases as a function of the resistance in the airways and the compliance of the lungs and chest wall together. So now when we superimpose the Guyton analysis, what happens? Well, when you apply PEEP, the right ventricular cardiac function curve shifts to the right. Okay, so that was the ghost of the right ventricular cardiac function curve that we see there. And what does that do? Well, it shifts the left ventricular cardiac function curve up and to the left by improving ventricular interdependence, right? As you shrink the right ventricular cavity, there's some stress taken off the left ventricle, so its cardiac function curve shifts up and to the left. As we just talked about, the increase in intrathoracic pressure can have really great effects on left ventricular afterload, so that also tends to shift the left ventricular cardiac function curve up and to the left. Similarly, as lung volume increases in the z-axis into the page, your pulmonary venous return, again, this is not systemic venous return, this is pulmonary venous return, it shifts to the right as well and tends to increase cardiac output even more as there's a great fraction of West zone 3 physiology within the lung, so as lung volume goes up, more blood is squeezed out, and therefore you tend to bolus. So you're essentially enhancing preload to the left ventricle and at the same time improving the diastolic and systolic properties of the left ventricle. So you can get an augmentation of your left ventricular output. So you can see that prior to putting the tube through this patient's vocal cords, you have a cardiac output that's way down here, okay, and a high distending pressure of the left atrium. You then apply some PEEP. You improve the compliance characteristics of the LV and its outflow characteristics by lowering afterload and improving its compliance by the application of PEEP. So you've improved your output on the y-axis, your blood flow. And then with the breath on top, you essentially just recapitulate the same physiology. As you apply increased intrathoracic pressure above and beyond the PEEP, then you transiently increase output, and then you transiently increase output as a function of improving your left ventricular cardiac function curve. Again, this applies to this here. And you're also, with the increase in lung volume with the breath, you're going to further bolus the left heart by increasing pulmonary venous return. And so again, what's the clinical implication of this? Well, this is a patient who is not volume responsive. They are on the flat portion of their left ventricular cardiac function curve. And now you've applied some PEEP, which results in a steady state improvement in your cardiac output. Okay, and then you're going to have phasic changes with each breath that the ventilator gives. So you decrease your RV size, you therefore improve LV compliance, you decrease left ventricular afterload with the positive pressure breath, and you shift your left ventricular cardiac function curve up and to the left, and you improve your pulmonary venous return, and you actually augment your LV output. Does that mean this patient who's having changes in their left ventricular stroke volume and pulse pressure variation, does that mean that this patient is volume responsive? Well, no, it actually could be a false positive. You've got to realize that this is physiology, that you're changing cardiac output not as a function of changing preload to a certain extent, but you're also changing afterload. You're changing the diastolic properties of the LV, and all of these things can contribute to changes in your left ventricular output, and it doesn't mean that the patient is volume responsive. Oh, there we go. I did highlight it going up there. Then on expiration, you're going to reverse that physiology. Okay, so expiration, what happens? Expiration, the right heart tends to be charged with blood. That impairs your LV compliance. You drop your pulmonary venous return a little bit as the lung volume is shrinking. But you're going to decrease your cardiac output transiently. So you can see now that this patient, from inspiration to expiration, can change their cardiac output. And this pulse pressure variation would be a false positive. But all in all, the application of PEEP resulted in a steady state improvement in left ventricular forward flow, and then you're going to have phasic changes in left ventricular output as a function of the increase in intrathoracic pressure with each additional positive pressure breath. So that was it for systolic heart failure. I hope you stay tuned for my thoughts on ARDS.